To be here, first of all, and I thank the organization committee for that. And so I'm going to talk about how to establish an RDN clinic. But in fact, it's not a clinic, it's a system or it's a program, because having a clinic is the easiest step. But having a referral system, having a complete follow-up, having complete setting, that's the most difficult part. And if you do a good job in that, the easiest part will be seeing the patient in the clinic. Every program has a goals, and you have to set your goals and then follow these goals to, the program will be tailored to that goals that you want. So for RDN clinic, the most important goal is, I think my colleagues already spoke about that, and I'm just going to go to the goal. So deliver an advanced care for resistant hypertension patients. The first step in the clinic is to confirm this patient has resistant hypertension, because most of the patients who are on 3 or 4 medications, but their blood pressure is actually controlled at home, but when they come to the hospital or to your clinic, they will have white coat hypertension or so forth. So first, we have to make sure that they have true resistant hypertension, no secondary causes, and to make sure that they are adherent to their medications. Giving you 4 pills doesn't mean that you are resistant hypertension if you're only taking 1 of them. So you have to make sure that these patients are adherent to their medications. I think a very important goal is to establish a referral and a follow-up system. It's not easy. It takes a lot of effort to get that structure, but with the hard work, you will find that result once you see your clinics are full because of that. And of course, having a structured RDN program, it will enhance your institution reputation, and it will be a great opportunity for research as well to test your patient, to test your population, and you do national registries and so on. So the first part actually of the referral system is you have to advertise for the clinic, and you have to do that with a collaboration with primary care, internal medicine, cardiology, and nephrology. So these are your suppliers. And of course, primary care, I reinforce on that point because they see tons of hypertensive patients, and their blood pressure is resistant, and they don't know what to do with them. So and a lot of them, they don't know anything about RDN because of the previous technology wasn't that effective, and the comeback is difficult. So a lot of them, they still think the RDN doesn't work. All right, so the way that I did it is I go there and I do presentations to the primary care, to internal medicine. In fact, I started with my hospital first. I did the presentation to cardiology department, and then after that to internal medicine, and then even to surgery. So by that, I have the referral system, internal referral system, and then I broadened my referral system strategy to even polyclinics. So I try to go and do presentations and have an open discussion with them about renal denervation. And as I told you, they have a lot of resistant hypertension patients that they don't know what to do. They keep adding physiotens or any other centrally acting medication, and the patient ends up with 5 or 7 medications, the blood pressure is still 170, 180. And they struggle. So once they see you, it's a relief for them. Please take the patient and try to control him in your hypertension clinic. Patient education is very important. Now we have a lot of platforms in terms of social media, in terms of podcasting and so forth. So that will increase the awareness of the patient as well. And of course, your hospital can promote for that as well in terms of hypertension day and doing some seminars and so forth. And finally, if you have a patient testimony, oh boy. Forget about it. So if you have a real patient to an experience or a personal experience about the treatment, that will be even an add-on to your advertising program. So now we did the advertising part. Then you have to put a structured, easy referral system. your criteria is clear. It has to be clear and easy and simple to understand. And most of the time, it's going to be a page of or a diagram from the guidelines. If the patient has blood pressure, uncontrolled hypertension on 3 medications, and GFR more than 40, this is definition of resistant hypertension, and he's qualified for RDN. And you have to have an easy access. Some of the physicians or some of the clinics will have 3 or 4 pathways or checklists, because the checkpoints before the patient comes to your clinic, and that's going to be hectic for the patient and for the physician to send a patient to you. And if you have a patient referred from a colleague, please do the feedback loop. That will increase the trust, that will make him refer more patients, and the patient and the referring physician will be happy for them. This is an easy step, which is how to set up your clinic. Of course, you have the normal setting, plus you have to have an access to the ambulatory blood pressure monitoring device, renal imaging, and the procedural tools. And of course, you have to explain the procedure to the patient. You have to tell him the risk, which is very low, and you have to tell him the chance of response. It's not a magical therapy. We know it works, but based on the guidelines that we have, every 4 patients, 3 will respond and 1 will not. So you have to tell him that, because if he is one of these non-responders, he's going to come every day in your clinic and saying that you promised me and my blood pressure is not good right now. You have to tell him the risk, and that's why in patients with that's perfect. If you choose the perfect patient, the chances is 3 to 1. But if you have a patient not fitting the guidelines, for example, CKD patients, I usually tell them it's 50-50. You may respond, you may not. Most of them they do, but according to the evidence that we have, it may help you, and since we already exhaust the medical therapy and the risk of complication is low, then why not we do it? For patients who are in dialysis, I don't think we have a problem with them, because you're not going to burn the kidney. But if the patient is so close to dialysis, I don't want to be the one that push into dialysis. So with a clear explanation at the end, it's going to be the patient's decision. Okay. We said about that, and shared decision is a very important part. Follow-up system is also important. You have to follow up the patient after 1 month, 3 months, 6 months. You don't need to follow this, but you have to have a close follow-up system. That will increase the trust. That will also give you an information for your data, your response, your procedural or your center data collection, and you can be able to publish based on that as well. The follow-up will also tell you about the continued quality improvement. You will see the first cases that you don't plate much, the response, and based on that, you will try to improve as well. We said, and having the program also will make you collaborate and expand. You will be partnered with other hospitals for referrals. You will build a training and research program and engage in RDN and hypertension societies as well. What additional useful ideas? Develop patient brochures and in Arabic and English as well. Implement telehealth follow-ups. Create hotline for referral physicians, and social media, of course. In conclusion, the RDN clinics equals a structured pathway to better outcomes. It's important to coordinate team and referral system, and there is a future opportunities in research and education. I will finish with one case presentation that we did last month. A 45-year-old gentleman with hypertension, blood pressure ranging from 150 to 170 over 90-100. Is diabetic and dyslipidemia. He is on Exforge, Concor, and Aldactone. That's 5 medications for hypertension. And of course, we know that the most common cause of resistant secondary hypertension is renal artery stenosis or renal disease. So every other cause were excluded, but for the renal artery stenosis, we do renal angiogram and to see if there is any renal artery stenosis, and in this case, we did not find any stenosis. We did 3 ablations on the right side and also, on the left side, and then we did renal angiogram, and we did also 3 on the right side, and his follow-up after 3 months, blood pressure 135/85. Actually, this patient was done last year, not last month. And 6 months, 135/88, and I saw him last week, blood pressure 136/87. All right, that's all.